good evening, delegates, and welcome to this live webinar focusing on the innovative use of ICG in oncoplastic breast surgeries. Our expert for the day, Dr. Sanjit Agrawal, will be sharing his insights and expertise on this cutting edge topic. We extend our gratitude to our knowledge partners, IRILIC, a part of Motherson Health and Medical, for their support in making this event possible. We're thrilled to embark on this first collaboration with them, and we look forward to many more in the future. During the webinar, delegates, if you have any questions, please post them in the chat box, and we will be having a dedicated Q&A session towards the end. So we will make sure that we are addressing all your questions. Now, I would like to hand over this session to Mr. Ashwin Somaya, the product manager at IRILIC, who will introduce our distinguished faculty. Over to you, Mr. Ashwin.
Thank you, Asabri. Good evening, Dr. Sanjit. I'm delighted to have you here with us today for a live webinar about the use of ICG in oncoplastic breast surgeries. A brief introduction. Dr. Sanjit Kumar Agrawal works as a senior consultant in the Department of Breast Oncosurgery at Tata Medical Center, Kolkata. His main interests include oncoplastic breast surgeries, sentinel lymph node biopsies, chest wall perforator flap-based breast reconstruction, post-mastectomy reconstruction, breast cancer research, and health economics. He has had an impressive track record of having performed over 3,000 breast cancer surgeries in the last 10 years. He has also published more than 40 breast research articles in index journals, presented abstracts at national and international conferences, and has been actively involved in many research projects. Welcome, sir. It's my pleasure to be a part of this webinar. And on behalf of the team, I'd like to thank you for sparing time and being with you this evening. Over to Dr. Sanjit.
So thank you very much, Aswin, for the kind introduction. So today, and thank you very much, Irlik, for giving me the opportunity to present this important topic for the surgeons who are practicing breast cancer surgery in India and abroad. So this technique was very useful in our experience, and we want to share our experience to the audience and how they can use ICG as a ICG as a important tool in the breast cancer surgery. Only confirm once. Can you see my slides?
Yes, sir.
So topic for the today is the role of fluorescence imaging in oncoplastic breast surgery. So introducing myself to the audience, I work as a senior consultant in Department of Breast Oncosurgery and academic officer at Tata Medical Center, Kolkata. It's in the eastern part of the India. So what is fluorescent dye? So fluorescent dye is available with the name of indocyanine green dye. So FDA has approved this in around 1959. It's a safe non-ionizing radiation. It binds with the lipoprotein to generate fluorescence. It's excreted through the bile. So if the patient is having a liver function derangement, so you need to be careful in using this dye in this group of the patient. It has short half-life and can be repeatedly used in every 15 minutes. So this is basic about indocyanine green dye. How it is available in India or abroad? So it's available as a Oro green vial, at least to us. I don't know what's the proper trade name for the abroad. So it is available as 25 mg sterile powder. So what we need to do to use this dye as an agent for injection or for the subcutaneous or for the IV, you need to dilute it with the 10 ml of the distilled water or normal saline. The maximum dose what you can give to the patient is 5 mg per kg. So suppose the example, if there is a 70 kg patient, the maximum dose is 350 mg. The safe dose is around 2 mg per kg. So when you are injecting this drug to the patient, you need to be careful about maximum dose and safe dose. So in the nutshell, it's a 25 mg powder. You need to dilute it in the 10 ml, and the final strength will be 2.5 mg per ml. Why fluorescence imaging? Because it is the only imaging available where you can in real time see the blood perfusion and the lymphatic flow. So it's not that it's only applicable in the breast cancer surgery. So it has wide use in the plastic and reconstructive surgery, hepatobiliary surgery, oral cancer, thyroid surgery, and it has really multiple use. So if you are thinking for including this equipment in your surgical department, it will be not used by you only. It will be used by the GI surgeon. It will be used by the head and neck surgeon, because it has multiple use across the disciplines. What is the basic of fluorescence imaging? It works between 700 to 900 mm. The tissue penetration of the infrared light is around 1 centimeter to 2 centimeter, and any setup, whatever you order for your use. So what generally happen, that you will inject the contrast agent either subcutaneous or IV. There will be a light source and fluorescence detector, and it will display into a processed image, and you can see in that monitor the processed fluorescence image. So it's a very simple technology. So you need to inject the contrast agent, there will be a light source, there will be a fluorescence detector, and ultimately the image will be synthesized with the help of a camera into a monitor display. So with the fluorescence imaging, we do two type of imaging. One is anatomical imaging and second is physiological imaging. It's nothing very complex. Anatomical imaging means you want to see the anatomy by injecting the dye in the subcutaneous area or the local anatomy. And the physiological imaging, when you are injecting the drug into the intravenous system and you want to see the blood flow of that ICG dye to the particular area of the interest. So anatomical imaging we use in multiple setting in the breast cancer surgery. The maximum usage limited to the, in general, to the sentinel lymph node biopsy. You can use it for the lymphedema surgery, lymphedema screening, axillary reverse mapping, and the lymphovenous anastomosis. And when you are injecting IV, you are trying to see the perfusion. So you can use it for the flap planning, flap perfusion, flap monitoring, and different approach of the oncoplastic breast surgery in our day-to-day practice. So what are the ICG benefit for the sentinel lymph node biopsy? So we all know the sentinel lymph node biopsy is generally done by the dual dye, because dual dye is the gold standard, because you can achieve a best identification rate and the lowest false negative rate by using dual dye. So what we were using before the popularity of the ICG, we were using the radioisotope dye plus blue dye, either methylene blue dye or isosulfan blue dye or patent dye. And what we found that with the dual dye, the accuracy is more than 95%. But when you are using methylene blue dye only, because of the logical issue of the radioisotope, the identification rate is generally less than 90%. That's the acceptable identification rate. And the false negative rate is generally more than 10%. That's the non-acceptable false negative rate. So the identification rate in any sentinel technology for the breast cancer surgery should be more than 90%, and the false negative rate should be less than 10%. But if you are using methylene blue dye alone or any blue dye alone, you will not achieve these targets by using single dye using methylene blue. Why not radioisotope dye? Because radioisotope dye need a nuclear medicine setup, and it has many logistic challenges that I will cover subsequently. And this is not that this is only is the problem to the lower middle income country. If you see the publication or the news from around the world, you will see that always there is a news for the, just like in the UK, Brexit risk supply problem for the nuclear medicine. In the COVID time, when the nuclear medicine facility was not available across the world due to the logistic issue, so it had major challenge to over nuclear medicine facility to the patient. And if we have some safer alternative and less costly alternative, it's better to use that and preserve the radioactivity for the different use. So coming to the radioisotope dye versus ICG dye, as I said, radioactive dye has the issue of non-availability. Radioactive dye may not be available always to you for the use. It has a legal issue. You need to ensure the isotope handling and disposal. You need to train the staff. Practical issue is that you need, if you have multiple patients posted for the sentinel lymph node biopsy, you need to shift the patient first to the nuclear medicine department, then the dye will be injected and the patient will be shifted to the OR for the surgery. And surgery has some time frame after the injection. It should be done within 6 hours of the dye insertion, and the cost is around 15K, and the patient is exposed to radiation also. Coming to the ICG dye, if you use similar use isotope, or it's similar use for the ICG dye, ICG dye is easily available around the world. It's FDA approved, easy handling and minimal training. So it's whole surgeon dependent. So you will inject the dye to the patient. You don't need to shift the patient to the nuclear medicine department. And it's because it's a non-radioactive isotope, you don't need to train the staff for the disposal and extra requirement. You can do as many as number of the patient you want, because you don't need to shift the patient, and you don't need to work on the time frame of the 4 to 6 hour after the dye injection. And you can post the case accordingly to your choice of the schedule, rather than dependent upon the nuclear medicine department. The cost in our setup is around 5,000 rupees if we are using ICG dye, and if we are using radioactive dye, it's between 15 to 20K. And in the last, the very helpful for the patient, because there is a no radiation exposure if we are using ICG dye, and it's very important for the patient. They are safer with the ICG compared to the radioactive dye with the radioactive radiation. So this is the way we use. So you can see in this picture, if you can see my cursor, we are injecting ICG dye. We use methylene blue plus ICG dye. This is the left side of the breast. We are injecting methylene blue dye. We do massage for the 2 minutes. So how much ICG need to be injected here? 1 ml or 2.5 mg. So now we use the ICG camera or ILRIC camera. We use ILRIC equipment. And after the injection, what you need to do, you need to put the tegaderm dressing. And this step is very important. Just after the injection, you seal that area with the tegaderm to avoid ICG dye spillage in the local area. Otherwise, you will not see the channel going towards from the breast to the axilla due to the spillage of the ICG dye. Once you have injected and you have done the tegaderm dressing over the injected site, you need to make the room dark. And this is, you can see this is the injection site, and this is the channel going towards the axilla, and you can really see in the real time the lymphatic channel going towards the axilla. This is the final picture. There will be two lymphatic channel going towards the axilla. You can earmark the lymphatics over the breast, and you can plan your incision accordingly as per the lymphatic marking over the incision. And you will see once you open the axilla, you see the fluorescent or the blue by the methylene blue, and this is the resected node. You can cross check with the fluorescent dye, so you can see the methylene blue visibly by the naked eye, and you can add the camera and see the fluorescence. So it's a blue plus fluorescent node. And the important step after this is that you can map the axilla using the fluorescent camera to see if there is any residual fluorescence in the area, to say that if there are any residual fluorescent node, you can remove that node and send this as a sentinel lymph node. So there are multiple steps. Is as simple as the sentinel lymph node biopsy we do. Extra thing what you need to add, you need to inject 1 ml of ICG dye apart from the methylene blue dye, and you will use the ICG camera to see the channel. It will guide you where you need to incise in the axilla to identify the lymph node. And finally, after the end of the procedure, after the end of the retrieval of the blue and fluorescent node, you can map the axilla with the ICG camera to see if there are residual fluorescent node, and you can remove that sentinel lymph node, that lymph node as a sentinel lymph node. This is a small video of the procedure. So this is the system we use. This is the monitor. You can see multiple the box here. So anatomical imaging, you can use white image, or you can use the color source. This is the camera, and you can see here the multiple buttons are here. This is for sensitivity. This is for the color. So this is the sensitivity, minus and plus. It go 1 to 5. So sensitivity can be 1 to 5. Then a snapshot. This is the injection of the dye. We inject in periareolar area. So this is the right side. We are injecting 1 ml of the dye. After blue dye injection, this step is very important. Use Tegaderm to seal that area to avoid spillage of the ICG. Do gentle massage for the 2 minutes. And after this, what we will do, you can remove the Tegaderm or you can let it be like this. You need to make your room dark and try to map the channel from the injection site to the axilla. If you are not seeing it, what you can do, you can increase or decrease the sensitivity. So if you can appreciate it, this is the injection site and this is the channel going towards the axilla. So with this method of the ICG, you can see the lymphatics going from the breast to the axilla. You can use the pen and mark the lymphatic channel from the breast to the axilla. And once you have marked the incision plan, open the incision. So this we have opened up. Because we have injected methylene blue, we can see with the naked eye that this is the channel here, and this channel is going towards the sentinel lymph node. We'll cross check with the fluorescence camera also. What you need to do, you need to make the room dark to see the infrared, and you can see beautifully here this channel, the breast channel, is joining towards the axillary channel and going towards the lymph node. The whole circuit of the lymphatics to the lymph node you can see with the ICG, and it's not possible by any other method using methylene blue or the radioactive dye, where you will see the from the injection site to the axilla, you can see the whole channel leading to the lymph node. So it will give you a lot of confidence that you are removing correct node and it's the first lymph node or sentinel lymph node of the patient. So once you have identified it, we'll dissect it and we'll remove it. So what precaution you need to take? Clip the lymphatics to avoid spillage. So you can see here I'm clipping the lymphatics to avoid spillage of the ICG in the local area, and we'll cut it. And after that, you can dissect it with the cautery or the scissor as per your preference and remove the sentinel lymph node. So this is the cavity now, the axillary cavity. So after this, what we do, we use the camera again and map the axilla for any residual fluorescence with the same camera. So you can see here, this is the cavity here, and this is the channel what we have clipped, and this is the cavity here, not seeing any residual fluorescence. So we'll complete the procedure here and we'll send the lymph node. You can see here again it's a fluorescent node. We are checking outside the body to see that it's fluorescent or not. So there are multiple cross confirmation you can do with the fluorescence camera. So what are the important steps? Very crucial and important step. Use always in combination with the blue dye. Why I'm saying it? Because if you have damaged the lymphatics by any means, the whole of the area will be fluorescent. So you need to color it with the methylene blue dye, and it's better. Use Tegaderm dressing in the injection site to avoid spillage and see the whole area fluorescent, and try to clip the lymphatics if you are seeing, to avoid spillage in the local area. So these are the institutional data we have generated. So we have done many study with the sentinel lymph node biopsy. Two important study what I need to quote here is one study which was published in the ASCO journal in 2020. So what we have done, we have compared technetium plus methylene blue dye with ICG plus methylene blue dye. Number of the patients were around 200 patients. And what we found that the ICG plus MB dye diagnostic performance is as similar as the gold standard technetium plus methylene blue dye. The identification rate was 97% with the ICG plus methylene blue, and identification rate with the technetium plus methylene blue dye was 95% in this study. Second study what we have published, it's a 1500 patient study where we have done sentinel lymph node biopsy. We compared all the method what we have used in the last 10 years, and you can see that the methylene blue plus ICG dye identification rate was the highest among all other method. Methylene blue dye alone, radioactive dye alone, or methylene blue plus radioactive dye, or methylene blue plus ICG dye. We compare all 4 methods and the identification rate was 98% with the methylene blue plus ICG dye. Number of the sentinel lymph node removed were almost similar in all the patients. So methylene blue 2.7 median number of lymph node, radioactive 2.3. The dual dye methylene blue plus radioactive 2.8 and methylene blue plus ICG was 3.4. With the ICG, because it's an ultra sensitive technique, you need to be careful that you are not removing too many nodes and you need to restrict the injection amount and you need to work in a time frame. You need to start the surgery as soon as possible after the ICG dye, because otherwise you will remove more lymph node. In our series also, the median lymph node what we removed was 3.4 and it's acceptable as per the international norms. To summarize, for the blue plus ICG sentinel lymph node biopsy, you need to inject 1 ml of methylene blue dye and do 5-minute gentle massage. After that, inject 1 ml of ICG dye, 2 minutes of gentle massage. You need to see the ICG, use the PDE camera, use the ICG irrelic camera or any camera, whatever you're using. Plan the axillary incision. The trick is here, avoid spillage of the ICG dye as much as possible. I suggest use pressure dressing after injection to the injecting site. Do meticulous dissection. And if you are seeing any lymphatics close to the lymph node, clip that lymphatics before cutting it. Axillary mapping is possible after sentinel lymph node removal to see any residual fluorescent node, and that should be removed and sent as a sentinel lymph node. Identification rate in our series and around the world is between 97 to 100%. Because ICG is secreted by the bile, if the patient has compromised liver function test, you need to be careful using this dye, rather use alternative method. The common problem of the skin necrosis and hypersensitivity reaction associated with the other dye is very less with the ICG dye. These are the anatomical imaging. When you are trying to use it subcutaneously and you are seeing the local anatomy. Coming to the next, the perfusion imaging. You are injecting in the blood vessel. So what we do, we inject IV injection of 2.5 mg, similar 1 ml of ICG dye, and you can use the perfusion technique to see the vascularity of your free flap, perforator flap or mastectomy flap. You can use it for the ICG assisted nipple sparing mastectomy, ICG assisted therapeutic mammoplasty planning. I will come to the individual use one by one. So flap perfusion, in our experience, if you have injected ICG IV and if you are not seeing the uptake of the ICG in your raised flap for any oncoplastic breast surgery, ultimately you will end up in the problem. It's a all or none rule. So this is the chest wall perforator flap I have done. You can see the vascularity here going, and whole of the flap is vascular. So suppose you will see the part of the flap is not taking ICG dye, it's better to trim that out and put the residual flap to cover the defect. Suppose you have done the mastectomy. So this is the mastectomy and you are suspicious that my flap or edge may not be vascular after mastectomy. So you can inject ICG again, IV, and you can see that the flap is vascular or not. And if you are seeing that marginal, just like here, the all is white and the marginal is black, you can trim out that amount of the flap and close the defect. So the flap perfusion, similar, you will inject 1 ml of the ICG dye, see with the camera that ICG is coming to your flap through that blood vessel what you have raised. And similar for the mastectomy flap perfusion. How we use in the nipple sparing mastectomy? So before nipple sparing mastectomy, we inject ICG IV. You can see the beautiful channel here coming from the internal mammary artery, third and fourth intercostal space towards the NAC. So you can inject before your procedure, use ICG, mark the vessel here that these are the major supply of the nipple, what you are planning to preserve by nipple sparing mastectomy. And during dissection, you will be more careful in this area from where the vessel is coming to the nipple areola complex. And after the dissection also, you can cross confirm by injecting ICG dye again, because half life is only 15 minutes. So if you are injected, you have done it, The whole thing will go in 15 minutes. Again, you can re-inject after doing nipple sparing mastectomy and cross confirm the nipple vascularity with the same vascular channel coming to the nipple areola complex. So it's a very useful for doing nipple sparing mastectomy using ICG dye. And you know that we do more and more nipple sparing mastectomy and implant whole breast reconstruction now. So, and if you're using prepectoral implant or direct to implant, the nipple sparing mastectomy, the nipple vascular supply and the skin supply is very important. And you can cross confirm the nipple vascularity by using ICG dye. You can inject it before surgery to give you an idea where you need to be careful in your nipple sparing mastectomy dissection. And you can use it for the incision planning also. You will plan the incision from where the vascularity of the NAC is not coming in the inframammary area. Coming to the therapeutic mammoplasty, if you are planning a therapeutic mammoplasty with the superomedial pedicle, we all know that superomedial pedicle, the supply is mainly from the internal mammary artery, the NAC supply. So you can mark, you can inject again the IV injection, see the vascularity, the major supply to the NAC, mark it over the breast, and you can plan the superomedial pedicle, including these vessels in your pedicle. So you will be more or less sure that you are preserving NAC vascularity, and it will help you in the planning of the therapeutic mammoplasty using ICG. Similar technique, 1 ml of ICG IV, use ICG camera, see the vascularity to the NAC, and plan your incision accordingly for the therapeutic mammoplasty incision. What are the newer technique we use? So we are trying to use it in ICG assisted tumor localization in impalpable lesion and ICG assisted lymphovenous anastomosis. For the tumor localization, traditionally we use wire. So what we tried, if we can see the clip with the ultrasonography, we inject a very small amount of the ICG close to that clip, and we use wire at present for the study, and we found that the concordance rate between the ICG and wire is around 90%. This is the old data of 16 by 18 patient, but we have done it for around 30 to 35 patient, and concordance rate between the ICG and wire is around 90% in our case series. And what you can do, if you are seeing the clip with the USG or by the any radiological method, you can inject a small amount of ICG in that area, and when you are operating, you can use the camera, see that the zone, and remove that excised zone and send it for a specimen mammography for final confirmation, especially if you are giving chemotherapy and after chemotherapy you are not seeing any lesion apart from the clip. So this injection can be done in the radiology department or can be done in your OR setting also only. Also, if you can see the clip or a smaller lesion with the ultrasonography, and it adds to the dissection, because with the ultrasound what happened, you can do USG guided excision too, but what happened once you lose the skin air interface by opening up the incision, ultrasound is very difficult to localize the individual clip, and with the ICG it will help in detecting you the area of interest using ICG assisted localization of the clip and residual lesion. Coming to the use in the lymphovenous anastomosis, we all know that now lymphovenous anastomosis is getting popular for the prevention of the lymphedema. Is a preventive approach. So this patient, we have done lymphovenous anastomosis. What you need to do, you need to inject the 1 ml of ICG dye here in the arm at the mid arm level, transverse injection. After axillary dissection, you map the ICG lymphatics here, and you join the lymphatics to the one of the vein from the axillary dissection to do the lymphovenous anastomosis. And I thank Dr. J.R. Anand for transferring this technique to us for using lymphovenous anastomosis using ICG dye. And we are in discussion at present. We are in discussion with the plastic surgery team to adopt this method as much as possible to do the lymphovenous anastomosis as a prophylactic step for prevention of the lymphedema. So as I said, it has multiple use in the breast surgery, from the sentinel lymph node biopsy to the flap perfusion to the localization of the impalpable lesion and to the lymphovenous anastomosis for the prevention of the lymphedema. We are doing a prospective validation trial for sentinel lymph node biopsy in the post-nicety setting with the help and supported by the Ehrlich team. So what we are doing in the node positive patient, if converted to node negative post chemotherapy, We are trying to do the sentinel lymph node biopsy with methylene blue plus ICG dye followed by axial lymph node dissection to see the false negative rate in this particular setup, node positive patient converted to node negative. As I said, the ICG is ultra sensitive, and you remove at least one lymph node more than the blue plus radioactive dye. So in the post necessity setting, as we know that if you remove 3 or more lymph node, the chances of false negative is less, and we are using this disadvantage of ICG as an advantage in this setting to see that the FNR can be reduced by using ICG plus methylene blue dye. We have already enrolled 40 to 45 patients in this trial, and probably will come with the result in next year to say that can you use MB plus ICG dye for using sentinel lymph node biopsy in node positive patient converted to node negative. Initially, what I have presented initially the data, it was limited to the node negative patient, but now we can use, if this trial will confirm the acceptable false negative rate and the identification rate, we can use it for the node positive patient too in selected group of the patient. So to conclude my presentation, what I will say that we have clinical success with the ICG dye. You can use the ICG dye for the real-time image guidance. As you have seen in the video, you can see the lymphatic channel, plan your incision, remove the blue plus fluorescent node, and send it for the frozen section if you want to do the frozen section decision. On table decision for the flap vascularity, you can use the patency check, and there is no radiation risk to the patient. So you are using a better science compared to the other available science by using ICG dye. We have better outcome. As I said, identification rate is best with the blue plus ICG dye. It reduces complication of the unexpected flap complication in the with the flap perfusion, and you can use ICG assisted procedure just like nipple sparing mastectomy or therapeutic mammoplasty to plan your procedure well, and reduce the complication rate as much as possible and give better outcome. What are the newer procedure? We are trying to use it for the lymphedema for the primary lymphovenous anastomosis, but you can use it by the plastic surgeon for the lymphedema treatment also. If the patient is having lymphedema and you are trying to do the lymphovenous anastomosis as a therapeutic step, you can inject the ICG dye, see the lymphatic, see the patent lymphatics, and do the lymphovenous anastomosis. You can use it in the OPD clinic also for the lymphedema screening by injecting ICG dye in the web space and see the lymph is going towards the heart or not. You can use it for auxiliary reverse making, is same as lymphovenous anastomosis. And there are some study from the US where people are using coated ICG, peptide ICG for the margin assessment. And this is very interesting area to explore in our setup also, that how we can use ICG for the margin assessment and reduce the margin positivity in the breast conservation surgery. The ultimately in all lower middle income country, we try to deliver the service with the lower cost, and ICG is very helpful in reducing cost to the patient, because you don't need to buy the expensive isotopes for the similar use. You don't need to set up the nuclear medicine department, and you don't need additional staff for using ICG in this setting. So with this, I will conclude my presentation, and I'm happy to answer any question. Thank you very much.
Thank you, sir, for that excellent presentation. So before we move on to the question and answers, delegates, thank you for joining us. Please start posting your questions and we'll be more than happy to take them. Also, I wanted to mention that if any of you have any inquiries and wish to know more about the iRelic products, please click on the inquire banner there that you see on the video page, and the concerned team will get in touch with you. So with this, we will now move on to the questions. Yeah, sir, please. I
So
think
we
there
have
is.
one question. What is the best technique for injection in sentinel lymph node biopsy, intradermal or subcutaneous? I will say in our practice, if you can inject whole intradermal, it will have best visibility with the ICG dye or methylene blue dye. But the problem with the intradermal, if you inject the whole dye intradermal, there is a chance of skin necrosis with the methylene blue dye. So you inject half intradermal and half parenchymal for the best result with the low complication rate.
Okay, there's one more question, Doctor. It's about the depth of penetration
Yeah.
with ICG. How is it managed when you're operating on high BMI patients, for example, where the layer of say fat tissue is extremely high?
So in the high BMI patient, as per our experience, you can see in 60 to 70% of the patient. But using early care camera has one advantage. You can increase the sensitivity of the ICG by from 1 to 5. We generally use the sensitivity at 3, but if you will increase the sensitivity to 4 or 5, yes, you will not see the whole channel, but you will see the tinge of the fluorescence from the skin, and it will guide you where the lymphatic channels are in the high BMI patient. So you can increase or decrease the sensitivity of the ICG by using this system. If you are mapping the axilla after sentinel node biopsy, you don't want to see the very minor fluorescence. You want to see that residual fluorescent node. You reduce the sensitivity. But if you are seeing a very high BMI patient and if you want to map the channel, use the high sensitivity. So you can decrease or increase the sensitivity as per the use and as per the requirement with this system.
Okay, thank you, sir. And how about the applications in other surgical oncology practices? For example, if you take gynec or head and neck, do you see this particular application being relevant to them as well?
So gynec surgery, I have seen people are using it for the sentinel node biopsy in the cervix cancer. They are using it if you are doing a boil resection, and if you want to see that which area is vascular or which area is non-vascular, you can again inject the ICG and see the boil vascularity. After anastomosis also, you can, if you want to see the margins of your anastomosis before doing anastomosis, you can inject and see that your margins are vascular or not. It has tremendous use in both the gynae and surgery. For the head and neck surgery, again, it's useful for the sentinel biopsy. And second, in the parathyroid, if you see the parathyroid is inherent iodine. So in the parathyroid, you can see use the ICG camera even without injection, and you will see that the parathyroid gland glowing. If you're doing a thyroid surgery and if you want to preserve the parathyroid, you can use the ICG camera to see the parathyroid.
Okay, thank you, sir. Thank you. Uh, do we have more questions from the audience, Asavri?
Yeah, let's wait for a minute or so and see if there are any new questions coming in.
Okay. So there's another question. How much dye would you inject to do a reperfusion scan, and how many times is it safe to use it during the same procedure in bilateral cases?
So the maximum tolerated dose is 5 mg per kg of weight. The safe dose is 2 mg per kg of body weight. So suppose it's a 70 kg patient, you can use up to 140 mg. So what we are using for the IV perfusion, we are using 2.5 mg. So we have used it at least twice or thrice in the same patient, and you can inject it after 15 minutes. That's the half life of the ICG dye. You can use it for 2 or 3 times because you are not crossing the even the safe dose limit, because we are injecting very minimal compared to the accepted safe dose, so 2 mg per kg, and we are injecting 2.5 mg only to see the vascularity for one time. And it's a very nice question. Thank you very much.
Yeah, the question was from Dr. Indrani Mukherjee. Thank you, doctor.
Uh, so, delegates, we are here for a few more minutes. If you have any questions, please keep posting them. In the meantime, I would like to announce that if any of you joined us late, please note that the recorded version of this event would be uploaded in the next 2 to 3 days, and you will be able to watch the same at the same link.
Can you please kindly elaborate on your experience with the post NACT cases? Because you did mention it. Can you just
So at present we are doing the trial, so we need to wait for the final result. And with the ICG means we have enrolled patient, but till now we have done sentinel lymph node biopsy in only 2 patients because we enrolled the patient, we have given chemotherapy, and now we are in the phase of doing sentinel lymph node biopsy. So I need little bit time to answer your question. Sorry.
okay? No problem. So thank you for that.
I think there are no more questions that we can conclude, and means you can
Yeah,
share my email address to the audience. If they have any question, you can personally text me or personally email me, and I will reply. I will be happy to reply.
sure, sir.
Thank
We'll do that.
yeah. Thank you so much, sir. Asawri, if you allow me, I'll just thank Dr. Sanjit for spending time with us this evening. On behalf of IRLIC and all the attendees, I extend our deepest gratitude to Dr. Sanjit Agrawal for his invaluable contribution to today's webinar. Dr. Sanjit, your expertise has profoundly enriched our understanding of this advanced technique. Your comprehensive presentation and discussion on the applications were truly enlightening. We are immensely grateful for the time and effort you dedicated to this event. Thank you once again for sharing your expertise and for your continued dedication for excellence in breast oncosurgery. We look forward to future opportunities for collaboration and learning from your vast experience. Thank you, sir.
Yeah, thank you very much to you and LabGuru team. So it was very hassle-free presentation and support by the team for this webinar. Thank you very much.